When the field was born, everything was about survival. We measure everything by how many more years can you live with this pump. But then when patients started living longer and their journey with this technology was dramatically increased, then we realized that it was not any longer about years of life. It was now about quality of life.
Welcome to Living Real Change, a podcast from Piedmont Healthcare. I'm your host, Dr. Lacey Knight, Chief Health Information Officer here at Piedmont. Join us as we highlight the people, the stories, and ideas that are transforming care and strengthening communities across Georgia. From inspiring patient journeys to expert health advice, each episode offers insight, hope, and a closer look at what real change looks like in healthcare today. In this episode, we sit down with Dr. Ezequiel Molina, Surgical Director of the Piedmont Heart Institute LVAD and Heart Transplant Program. Under Dr. Molina's leadership, Piedmont performed 103 heart transplants in 2024 alone, surpassing the total from the program's first 10 years and ranking Piedmont among the top 5 programs in the country. Dr. Molina explains what heart failure really means and shares the key signs that indicate when it's time to seek specialized care. He also discusses the future of heart failure treatments and his vision for expanding access to life-saving care across Georgia. Very excited to talk to you, Dr. Ezequiel Molina. Made Atlanta your professional home and really taken on the challenge of building one of the country's leading heart failure programs. Maybe you could tell me a little bit about how you started with this mission and kind of what your vision is for the program.
Sure. Well, my mission has been to help, patients with advanced heart failure. It is a pandemic in the U.S. and especially in the southeast of the country. And my mission is to help as many patients as possible. We have developed a very comprehensive program, not afraid of taking on risk and, again, offering the therapies that we offer to as many people as we can.
Yeah, and I think you've really done an awesome job since you've been here in really just a short time. This program has grown tremendously.
If I can interrupt you, I want to say that it's obviously not me. This is, in this field, nobody can claim that she or he can take care of these patients by themselves. This is it takes a village to take care of these patients. They're very sick. So fortunately, we have a phenomenal team, including obviously surgeons, cardiologists, coordinators, nurses, nurse practitioners, ICU care, operating room people, administrators. I'll be unfair because I'm going to be leaving people out here, but the entire team is fantastic, and that's the reason for the success
Sure.
of the program.
Thanks for taking a moment to bring attention to all the folks involved in great care. I want to follow up on something that you mentioned about the notion of this pandemic in Atlanta in the Southeast. Heart failure is a pandemic. Can you maybe, for our audience, just describe what you mean by that?
Sure. So people probably are aware that heart disease is the number one killer in developed countries, and the U.S. is no exception. Heart failure is one of those heart conditions, and it's taking over us. Used to be clearly heart attacks that used to kill the most people. Eventually will be heart failure, actually. More than 6 million people live in this country with heart failure. Almost 1 million of those 6 millions live with an advanced stage, meaning end-stage heart failure, stage D. And this disease causes 250,000 deaths per year, and obviously represents a tremendous burden for the healthcare system. So I always say that obviously COVID had a huge impact in our lives. It was a tremendous problem for humanity and for our country and for everybody. But heart failure is not as bad as COVID, even bigger than COVID as a problem for the healthcare system. And that pandemic continues. It's actually getting worse. Outcomes for the treatment of this condition, there are some studies that show that are actually less effective than before, meaning more people are dying of heart failure than ever. And the southeast of the country, for many reasons, I think is particularly affected by this. And some studies show that outcomes for advanced heart failure treatment are actually worse in the southeast of the country than in other parts of the country. So this is a very big challenge for all of us.
It sounds like, and it is interesting to hear that because we've gotten so good at treating acute heart attacks, that we're seeing more people
Right.
develop heart failure, which is really kind of, I guess, the next level of complication related to underlying heart disease.
That's right.
So it's uncommon to have a program as strong as what we have at Piedmont. Could you maybe talk about really what might be, I would say, more commonly available in communities, and how what we may offer at Piedmont might be a bit different?
So, heart failure, it's a silent disease for many patients. They developed this condition over the years, and I think it's human nature to adapt to change and not really realize that, for these patients to be able to tell that they're not able to do the same things they were able to do in the past. They just feel like, they're getting old, or they're getting overweight, or just life is difficult. And symptoms sometimes don't become very, very obvious until very advanced stages, when patients develop cardiogenic shock. And when you develop cardiogenic shock, your heart is now not able to pump enough blood to organs and tissues. And this is when patients present to hospitals in like ours, in extremis. They come in with a very low blood pressure. The kidneys have shut down, the liver has shut down. They probably need to be placed on a ventilator and need to receive IV drugs to sustain life. And many of those patients crash on temporary support devices, mechanical pumps that are designed to rescue these patients from death. And sometimes these patients get seen on the community by the care system, but heart failure is not recognized. That's a big problem, and there is a tremendous opportunity that is missed about sending these patients to us earlier, when we implement some of these therapies that we have that can have better outcomes or better results when implemented earlier. So, unfortunately, in 2025, most of the patients we see come to us through this cardiogenic shock pathway, meaning they come in truly in shock. And at that point, the only two life-saving therapies that exist are number one, heart transplantation, which is the gold standard therapy for advanced heart failure. And number two is a mechanical pump that is implanted into the chest, called an LVAD, the left ventricular assist device. So those are the advanced therapies that we have, that obviously are not available at every hospital in the country. There are only about 100 to 110 transplant programs in the country out of thousands of hospitals, and there are only about 200 LVAD programs in the country. We belong obviously to Piedmont Health, which is the largest healthcare system in the state of Georgia. So we have the opportunity to receive a large volume of these patients with advanced heart failure, and that's probably the main reason why we're such a busy heart failure center. Last year, we implanted 91 LVADs. We were the busiest LVAD program in the country. And this year, we have already implanted 71 LVADs, and it's only half of a year.
Wow.
So we will probably be above 100. And we could set this year a world record, actually, for the number of LVADs implanted by a single hospital. And on the transplant side, we went from just performing few transplants 3-5 years ago, less than 10 a year, to 103 last year. We became the fourth busiest heart transplant program in the country. And we were able to also develop a combined heart-kidney transplant, because many patients, when they present with advanced heart failure, also have kidney problems. And we have had fantastic collaboration with our kidney transplant colleagues here at Piedmont, who, by the way, also have a very successful kidney transplant program. So we aligned our efforts and created a heart-kidney program, and we performed 15 transplants last year with excellent outcomes. And that means that now many of those patients don't have to leave the state to nearby states to get those therapies, or even more. Some of those patients could never make it to go see another team out of a state, and many of them died. So now we have the opportunity to provide this service to Georgians that they didn't have access to this in the past. We will soon align our efforts with our liver transplant colleagues, and we'll start doing heart liver transplants. So our program keeps growing, keeps offering more and more complex therapies, and these are just a few of the most advanced therapies that we use. Our um, cardiologists, they offer several different therapies, including medications, IV inotropes, valve therapy with transcatheter approaches, electrophysiology procedures, open heart surgery procedures. And I don't want to forget about our ECMO program. When patients come in shock, crashing, and burning, our ECMO program is one of the busiest in the country as well, and they have formed a phenomenal team that helps many, many patients.
Thank you for that background and insight. I want to spend a little bit of time kind of breaking down some of the terms that you referenced in here. I think the first thing is, even the idea of heart failure sounds absolutely horrifying, and I think you did a great job describing these kind of critically ill patients that are presenting into the health systems seeking care. Could you maybe at the very basic terms explain, what exactly does heart failure mean?
Sure. Thank you. This is a very important question. I appreciate that you're asking me. The heart failure at an organ level means that the heart is suffering changes that prevent it from performing its function normally. Okay. So the heart is a pump. It just pumps blood to all organs and tissues in the body. So heart failure occurs when the heart is unable to perform that function. But there are different levels, obviously. It's not an on-off situation or a black and white situation. You start with a stage A heart failure, which is when you have risk factors to have heart failure. For example, you have some of the most common diseases. You have high blood pressure, diabetes, coronary disease, etc., or a history of heart failure or heart disease in your family. That puts you at risk of having heart failure. As the disease progresses, the function of the heart deteriorates, and then you start manifesting symptoms. And some of the most common symptoms are the following. The most common one is perhaps shortness of breath. You're unable to perform the activities of every day because you become short of breath when you do them. For example, climbing up flights of a stair, walking on flat surfaces for a period of time, exercising. It becomes more and more difficult because you can't breathe. You're short of breath.
So, quick question about that. You mentioned earlier that some people just automatically attribute this to age, or maybe out of shape. I haven't exercised for a long time. What would be some of the things that you think maybe should get people to think about maybe going to talk to somebody about this difficulty breathing that's new? What might be something to maybe for some of the listeners just to not automatically think that this is because I've gotten older or because I'm out of shape, but to actually think, maybe I need to talk to somebody about this.
That is a great question, and obviously, when patients start developing symptoms, usually, people take a step back and give it time for the symptom to improve. But I would say when those symptoms don't get better, and you really recognize that you're unable to do the things that you used to do, you should consult with a physician. The diagnosis of heart failure obviously carries an emotional component, but it is better to be sure than to let those symptoms go for a prolonged period of time, and the disease gets progresses and gets worse, and then your options are not as wide as at the beginning of the disease. Sometimes just by changing by lifestyle modifications, by losing some weight, eating better, avoiding salt, or even exercising more, these symptoms can get better easily. But when patients continue to experience these symptoms for years, and they're not seeking for help, then is when an irreversible damage to the heart can occur. So I think we all know our bodies well, and sometimes we're just not having a good day, or we didn't sleep well, or we have a cold, and those things I think most of us can easily sort out and attribute new symptoms to any of those things. But if this persists over weeks, I think it's reasonable to look for help.
Thanks for that advice.
At Piedmont, quality care changes lives. Meet Brad, a healthy former Marine who unexpectedly suffered 5 heart attacks and then heart failure. He credits Piedmont with saving his life.
The teamwork it took to provide me a path forward through a surprise heart failure and almost 5 months of intensive care in 3 different Piedmont hospitals is difficult for me to even imagine, but you guys nailed it. How do you thank someone for the gift of life?
Hear more at piedmont.org/qualitycare. Piedmont, real change lives here.
The next piece I want to dive into, you referenced this term, mechanical pump, LVAD, I think was another term. One we were talking about before this started, just my familiarity with that in the emergency department. And then I think this always makes me think back in the early days to Dick Cheney.
Sure.
And maybe the most unintended celebrity for what modern medicine could do at the time. And I think at the time this was something that was called really bridge therapy or transition therapy. So maybe you could explain it at its basic, what the LVAD is, how it works, and then maybe talk about this idea of either bridge therapy, destination therapy, or how this technique fits into the options for advanced heart failure.
Thank you. All great questions, obviously. So, cardiac surgery was born as a specialty in the 50s with the development of the heart-lung machines that allowed surgeons to stop the heart and work inside. And started also with, treating young patients with congenital conditions, so heart deformities that babies were born with, and then expanded to valvular disease and coronary bypass grafting in the 60s and 70s. So the scientific community around cardiac surgery has always been working with different types of machines to support those operations and be able to stop the heart. But then scientists realized that despite the existence of cardiac surgery procedures and medications, many patients would die because of heart failure, hearts that were just we were not able to fix. So the idea of creating machines that could take over for the function of the heart was born. And as early as on the 60s, the 1960s, scientists created the first total artificial heart, which is a machine that completely replaces a heart, and also ventricular assist devices, which are, as the name implies, they are pumps that assist the heart. They don't completely replace it, but assist the function of the heart. So ventricular assist devices. The first attempts at creating those pumps were not very, very successful. It wasn't until the late 90s, early 2000s, when the first device that could support patients for months or a few years was created, and that technology has dramatically improved over the last 2.5 decades. And we now have two groups of machines. Have machines for temporary support, so machines that can be used for a week or a few weeks, and we have machines that can be used for years, for longer term support. So that the temporary machines are machines that are used on those patients that we were talking earlier that present to the hospital in shock. For example, ECMO. ECMO is a machine that typically gets connected to the big vessels in the groin, where a big hose is placed on the vein to withdraw the blood from the patient, and another big hose is placed, or catheter is placed on the artery to return the blood. And with that, we can save a patient's life that comes in extremis, in shock, that without that technology would definitely die. And with those machines, we can quickly support the life of those patients until we come up with a better plan, a better long-term plan. So those are acute or temporary support devices. So once patients are rescued from that situation, then they need a long-term strategy, a strategy that allows them to go home and continue living a normal life. You can't go home on ECMO. ECMO is a machine that can be only managed in the hospital. So for this longer-term approach, these LVADs have been created, and also total artificial hearts, but LVADs are much more common than total artificial hearts. These are devices that are implanted inside the chest at the tip of the heart. They act as a pump, basically. They do the same thing the heart does. And one connection is to the heart itself, a chamber where the blood returns to the heart, the left ventricle. And then they have a hose that is connected to the aorta. The aorta is the main artery that lifts the heart and distributes the blood everywhere in the body. So this pump takes over the function of the left side of the heart by pumping blood in this way. And the pump that is approved by the Food and Drug Administration these days, the HeartMate 3, is by far the best pump we've ever had. Now, this pump can keep patients alive on average for a period of 6 to 7 years. So that is average.
Wow.
So that means that if we put these pumps on 100 patients, 50 of them will live between 6 and 7 years after the implantation. Okay, so now we're talking about patients that can go home, can exercise, can travel, can get married, can have kids. The only thing they cannot do realistically is to get immersed in water.
Sure.
Okay. And the reason for that is because the pump uses so much energy. Remember, these pumps take over the function of the left heart, the part that is damaged, and they pump between 4 and 5 liters, in some patients even more than that, per minute. So that consumes a tremendous amount of energy. So there are no battery systems that are completely implantable yet that can sustain that type of energy requirement. So these pumps have a cable that comes through the skin and connects to a couple of batteries on the outside and a small computer. Obviously, that is the price these patients pay for living that long, is carrying that equipment with them and not being able to immerse in water. But these pumps are absolutely phenomenal these days. Obviously, it's not what God gave us, so they have a profile of certain complications, but those have gotten better and better over time. And the quality of life of most of these patients is actually excellent. So not only they live longer, but they live a good life. They're able to resume their exercise, their job, and have a good quality of life.
That's
and
great.
As you pointed out, some of these pumps are being implanted as a bridge to a transplant. So if you're younger, for example, and you can't wait for a transplant, you can have one of these pumps implanted and live for a few years with a pump. And later on, when a heart that fits your needs, shows up, then you can be converted to a transplant patient. Some patients are not transplant candidates, unfortunately. Either they have certain diseases, or they're too old, or they have different problems. And so you can get one of these pumps as what we call destination therapy, meaning, you get the pump as the destination. And you will live for as long as the pump is able to help you.
That is really very interesting. I think it also gives you some level of insight of how good the heart we're born with really is at performing and functioning when the demands of these advanced machineries really have a lot of trouble keeping up with them.
Yes.
So thank you for also sharing some anecdotes about how these patients that are using the LVADs actually have improved quality of life and are able to do things that they maybe didn't expect to be able to do.
That's right. For us, that's an absolute, key aspect of what we do. When the field was born, everything was about survival. We measure everything by how many more years can you live with this pump. But then when patients started living longer and their journey with this technology was dramatically increased, then we realized that it was not any longer about years of life. It was now about quality of life. So I think it is important that the audience understands that, except the limitations that I mentioned, the quality of life of these patients is actually excellent.
Okay. Thank you for that. So, if you were to predict the future and see where the technology is going, where patient care is going, what do you think is going to happen, in the next 5, 10, 15 years with available treatment options for heart failure patients?
I will answer your question in two groups. In the field of heart transplantation, I think we are experiencing very, very important developments on the side of organ recovery. Probably the audience is not aware that historically we've been getting hearts from patients with brain death. But for the last several years, started in Australia, New Zealand, and also England, and now in the US, we can obtain donor hearts from people that actually are still alive, but they carry a diagnosis that is terminal, and they offer their organs after care is withdrawn. For example, they're in the ICU, they have a pretty significant neurologic injury, but they're not brain dead, and the family decides to withdraw support because there is no hope that it will recover. So this is a new concept, a relatively new concept, is donation after circulatory death. And now about 20-30% of the transplants that we do come through this pathway. And I think this is a very important development that has fueled the number of transplants that we can perform in the country. Historically, we've been able only to perform 2,500 transplants per year. Now, last year, for the first time, we reached 4,500 heart transplants. So we're doing more heart transplants because there are more donors. There is technology now that allows us to preserve the organs for longer distances. For example, something fantastic that happened about a year and a half ago, a heart taken from the Caribbean was transported transatlantically through the ocean into Paris, and it was implanted in a patient in Paris. The organ even went through customs.
Oh my goodness.
In between countries. So we're able to fly much longer distances now to transport organs, and this is allowing us to do more and more transplants and considering more and more patients for heart transplantation. Eventually, the panacea will be xenotransplantation, where we can harvest organs from animals and be able to use them in humans. There have been 2 recent attempts at that unfortunately did not have good outcomes, but that will eventually be fixed and will be a reality. On the LVAD side, the biggest transformation will probably be the development of pumps that are fully implantable, meaning this downside of the pumps having this cable coming through the skin and carrying these batteries and computer on the outside and not being able to get in a swimming pool or in the sea, that will change. Eventually we will be able to implant an LVAD completely inside the body, and we will be able to give these patients a better quality of life than the one they have right now. So there are multiple developments going on. I'm very enthusiastic about the future. I think, as companies and scientists get challenged with, new ideas, I think science will make more progress and we'll be able to offer patients better therapies.
Amazing. I had no idea. We're talking about an area of medicine that is really so specialized, and yet the runway for opportunity is still so extensive.
Yes.
I really can't believe that story about the long distance for the transplant and then the other organ recovery techniques. That really, really, really fascinating. Thank you for that. I think the last question I have for you, I've made a couple of notes really kind of highlighting that if anybody listening has some persistent difficulty breathing or really just doesn't have the energy to do the things that they were accustomed to doing, that might be a good reason to get checked out. I heard you really give a lot of reason for people to be optimistic in what's available today, the future of medical therapies, the future of surgical therapies. And I just want to give you an opportunity to share any final thoughts really for our listeners, anything that you'd like to share, bits of advice that you'd like to give folks before we close.
I thank you for the opportunity. I really, I'm grateful for that. I want to talk to the patients who, have symptoms, or patients who've been told that they have heart failure. So heart failure is a terrible disease, and it can definitely lead over the years to death. And we have a number of treatments that are very successful at, improving those symptoms, prolonging life. I think I want to make a call to, patients and physicians in general. When patients develop heart failure, I think it's fair that they get referred to advanced heart failure specialists. The same thing that when patients get diagnosed with cancer and they always get referred to a cancer specialist, I think the same thing should happen with advanced heart failure patients. We will never implement any of these therapies until the time that patients need them. But I think getting an early evaluation and getting to know those patients and establishing certain metrics of progress and is very important. So please, if you're a patient with advanced heart failure, I think you probably should know that in 2025, you have the right to be seen by a physician who is trained to treat a condition like the one you have. And so seeing an advanced heart failure specialist is important. And for physicians listening to this podcast, if you take care of these patients, please allow us to evaluate them as well. We will never, take these patients away from you. We will only offer therapies like the ones we discussed today once the time comes for those patients to receive them, and we'll send those patients back to you. But I think, like anything in life, things get specialized, and the group of physicians and other team members here at Piedmont, this is what we do every day, 24 hours. This is the passion that we have. So please trust your patients to us. We will take absolutely the best possible care that they can receive.
Thank you for listening to Living Real Change. To hear more stories from across Piedmont Healthcare, be sure to subscribe and watch for upcoming episodes. For additional health tips, news, and resources, visit us at piedmont.org/living-real-change.